Welcome back to the Deep Dive. If you've ever waded into chronic disease management, especially diabetes pharmacology, it can feel like, well, drinking from a fire hose.
Absolutely. There's just so much information.
So today, our mission is really to cut through that noise. We're using the sources you sent in to distill the really critical high-yield stuff on glucose control, the big differences between diabetes types, and, importantly, all the major drug classes used.
Right. And we're structuring this to give you a kind of clinical map. We'll start with how the body should work, glucose homeostasis, and then pinpoint exactly where things go wrong. Is it a total lack of insulin, like in type 1? Or is it more about resistance, like in type 2?
Okay.
Because understanding that difference is the key to choosing the right therapy. We'll hit the mechanisms, the risks, the safety alerts you just have to know for each drug class.
Perfect. So let's set the scene. The body's normal control system, it all centers on the pancreas, right? The dual-purpose organ.
Exactly. For blood sugar, we're focused on its endocrine job. Specifically, what happens in the islets of Langerhans. It's this delicate balancing act
In between.
between insulin from the beta cells and glucagon from the alpha cells. Insulin acts like a key, letting glucose into cells so blood sugar goes down. It also stores extra glucose as glycogen, mostly in the liver and muscles.
And glucagon does the opposite.
Right. Glucagon races blood sugar when needed by breaking down that stored glycogen. It's called glycogenolysis. When everything's working perfectly, this back and forth keeps your blood glucose nice and steady, somewhere between 70 and 100 milligdl.
So what happens when that perfect balance gets, well, completely thrown off? What's the breakdown that leads to those classic, sometimes really severe diabetes symptoms?
It's a strange situation, really. It's like cellular starvation happening right in the middle of plenty.
Hmm.
The glucose is there in the blood, but the cells can't use it, so the body tries to get rid of it.
Leading to...
The famous three polys. First, all that extra glucose gets filtered by the kidneys, and it pulls a ton of water with it. That's osmotic diuresis, causing polyuria, frequent urination.
Okay, makes sense.
That massive water loss leads to dehydration, which triggers intense thirst, polydipsia.
Got it.
And even though there's plenty of sugar around, the cells are actually starving for energy. So the person feels excessively hungry, polyphagia. But often they're losing weight because they can't use the fuel they're taking in.
And clinically, how do we confirm this? What are the key diagnostic numbers?
Well, the immediate snapshot is hyperglycemia, which we usually define as a fasting blood glucose over 126 milladl. But for tracking management over time, the really crucial number is the hemoglobin A1C.
The A1C. Right, why is that one so important?
Because it's not just a snapshot. It reflects your average blood glucose control over the last, say, 2 to 3 months. It shows how much glucose has stuck to the hemoglobin in red blood cells.
Kind of like a long-term report card?
Exactly. And for most patients managing diabetes, the goal is usually to keep that A1C at 7% or less. Hitting that target consistently is what helps prevent those really serious long-term complications.
Okay, so the system fails, but how it fails makes all the difference. Type 1 versus type 2. Let's really nail down the fundamental distinction here.
It truly boils down to presence versus absence of insulin production. Type 1 diabetes mellitus, Q1DM, is the absence scenario. It's an autoimmune attack that destroys the insulin-producing beta cells in the pancreas.
Total destruction.
Pretty much. So there's virtually no natural insulin being made. This accounts for less than 10% of cases, often starts in childhood or adolescence. And because there's no insulin, treatment always, without exception, requires giving external or exogenous insulin.
And their big immediate risk.
Is diabetic ketoacidosis, or DKA. This is a life-threatening emergency. You get sky-high blood sugar, plus the body starts breaking down fat for energy, producing ketones, which makes the blood acidic.
Okay, clear contrast now with type 2 diabetes mellitus, T2DM. This is the much more common one, right? Linked heavily to obesity.
That's right. About 90% of cases.
Yeah.
And here, it's not primarily about destruction. It's more about inefficiency. The core problem is insulin resistance. The insulin is there, maybe even lots of it initially, but the body's cells don't respond properly to it. Like the keys are there, but the locks are rusty.
And eventually the pancreas gets tired.
Exactly. Over time, you often get a relative insulin deficiency too as the beta cells wear out, trying to overcome that resistance.
Yeah.
So treatment starts differently. Lifestyle changes, diet, exercise, weight loss are huge. Then come oral medications. Insulin might be needed, but often much later.
And the acute risk for type 2, different from DKA?
Yes, typically. Because there's usually still some insulin around, it prevents that massive ketone production. Their acute risk is more often hyperosmolar hyperglycemic syndrome, HHS, You still see dangerously high blood sugar and severe dehydration, but usually without the significant acidosis you see in DKA.
We should also briefly touch on gestational diabetes. Develops during pregnancy.
Right, it often goes away after delivery, but it's a major red flag. Women who've had it have a much higher risk, maybe up to 30%, of developing type 2 diabetes later in life.
And the treatment during pregnancy itself.
Critical point. Insulin is the treatment of choice. Oral agents generally aren't recommended because we just don't have enough solid safety data for their use during pregnancy.
So, regardless of the type T1, T2, gestational, the real endgame isn't just getting the blood sugar number right today, it's about preventing the long-term damage.
Absolutely, that's the whole point. We're trying to prevent the big vessel problems, the macrovascular complications like heart attacks, strokes, peripheral artery disease,
Yeah.
and also the small vessel damage, the microvascular issues, retinopathy that can cause blindness, neuropathy causing nerve pain and numbness, and nephropathy leading to kidney failure.
Okay, let's pivot to treatment then, starting with the cornerstone for type 1 and often needed later in type 2, insulins. There are several types, and their timing seems crucial. Can you break down the main categories, maybe using that runner analogy?
Yeah, a runner analogy works well. It's all about speed and duration. Think sprinters, middle distance, and marathoners. Their speed determines when the patient needs to eat.
Okay, so who are the sprinters?
Those are the rapid-acting insulins. Think Lispro, Humalog, Aspart, Nuvolog. They kick in super fast, like within 15 minutes.
Wow, 15 minutes. So the nursing implication there must be.
Huge. You absolutely must make sure the patient has their food right there and starts eating within about 15 minutes of getting the injection. If they don't, their blood sugar could plummet. Hyperglycemia. Very dangerous.
Is that inhaled one, Afrezza, also in this group?
It is, yes. Afrezza is inhaled, also rapid-acting, but it has a very serious black box warning. It's contraindicated, absolutely should not be used in smokers or anyone with chronic lung disease like asthma or COPD because of the risk of acute bronchospasm.
Got it. Okay, moving on from the sprinters, the middle distance runner.
That would be short-acting insulin, which is basically regular insulin, sometimes called R. It's a bit slower, starts working in about 30 to 60 minutes.
So give it about half an hour before the meal.
Exactly. And the really key thing about regular insulin, the unique thing, is that it's the only insulin formulation that can be given intravenously, IV.
Oh, okay. So if someone comes in with DKA needing IV insulin.
It's going to be regular insulin with IV. It's just the formulation that's stable and reliable for that route, essential for managing those acute crises.
Makes sense. Then we have the longer acting ones.
Right. Next is intermediate-acting NPH insulin. You'll recognize it because it's cloudy or opaque. It has a slower onset and lasts longer, maybe 10 to 18 hours. Because it's intermediate, it's often mixed in the same syringe with regular insulin.
And finally, the marathon runners, the ones providing background coverage.
Those are the long-acting insulins. Examples are Glargine, Lantus, and Detamir, Levemir. They provide a steady, sort of peakless basal insulin level over roughly 24 hours. They mimic what the pancreas does naturally between meals and overnight.
Anything special about administering them? Can they be mixed?
Big point here. The long-acting ones, especially Glargine, cannot be mixed in the same syringe with any other insulin. Glargine is formulated at a low pH to make it release slowly, and mixing it would mess up its absorption profile completely.
Okay, that's crucial. Now, dosing strategies. We hear about sliding scale versus basal bolus. What's the difference and why does it matter?
Well, the traditional sliding scale involves checking blood sugar and giving a dose of short or rapid-acting insulin based only on that current number. The problem is it's reactive. You're treating high blood sugar after it's already happened.
Right.
The preferred method now, especially in hospitals, is the basal bolus approach. This tries to mimic a healthy pancreas more closely. You use a long-acting basal insulin once or twice a day for background coverage, plus doses of rapid-acting bolus insulin before meals to cover the carbohydrates eaten, and maybe extra correction doses if needed.
That's more proactive.
Exactly. Now, speaking of dosing dangers, you mentioned U500 insulin earlier. Why is that one flagged as high alert? Because it's incredibly concentrated.
Yeah.
Standard insulin is U100, meaning 100 units per milliliter. U500 is 5 times stronger, 500 units per ml.
Wow. So the risk of overdose is huge.
Massive. If you accidentally draw up U500 insulin using a standard U100 syringe, you'll get 5 times the intended dose. That could easily be fatal. It is absolutely essential to only use a specific U500 syringe or a dedicated U500 insulin pen for administration. No exceptions.
Crystal clear. And one last safety tip about mixing. You mentioned NPH and regular.
Right. If you need to mix NPH, which is cloudy, and regular, which is clear, in the same syringe, Remember the mnemonic clear before cloudy. You always draw up the clear regular insulin first, then the cloudy NPH. This prevents accidentally contaminating the regular vial with the NPH suspension.
Okay, meticulous attention to detail needed there. Let's switch gears now to type 2 management, focusing on the oral drugs and the non-insulin injectables. These are designed more to tackle that underlying resistance and relative deficiency rate.
Precisely. And the undisputed first-line agent here is metformin, which belongs to the biguanide class.
Why first line? What makes it the go-to?
Its mechanism is really effective. It primarily works by reducing the amount of glucose the liver produces. It also helps improve the sensitivity of insulin receptors in the body tissues. And a huge advantage, because it doesn't directly stimulate the pancreas to release more insulin, metformin, when used alone, generally doesn't cause significant hypoglycemia or weight gain.
That's a big plus. But it does come with some serious warnings, especially concerning the kidneys and certain medical procedures.
Absolutely critical safety point. Metformin carries a risk of a rare but potentially lethal side effect called lactic acidosis. This risk increases significantly if the patient has kidney problems, because the drug is cleared by the kidneys. So it's contraindicated if the renal function is poor, generally a creatinine clearance below 30 ml/min.
And the contrast dye issue?
Yes. Iodinated contrast media, used in many radiologic studies like CT scans or cardiac catheterizations, can temporarily impair kidney function. So the rule is, metformin must be discontinued on the day of the procedure and held for at least 48 hours afterwards until kidney function is confirmed to be stable again. This is a non-negotiable safety measure.
Definitely a life or death detail. Okay, if metformin is the current star, what was maybe the older workhorse class before it gained such prominence?
That would likely be the sulfonylureas, drugs like lipizide, glucotrol. Their job is basically to stimulate the pancreas, whatever functioning beta cells are left, to secrete more insulin.
So they squeeze out more insulin. What are the downsides of that mechanism?
Well, the obvious ones are hypoglycemia, because you're forcing insulin release regardless of blood sugar and weight gain, which is often linked to increased insulin levels. Also important to note, if a patient has an allergy to sulfon antibiotics, there's the potential for cross-allergy with sulfonylureas.
Got it. Then there are the glinides like repaglinide, Prandin, similar mechanism but shorter acting.
Exactly. Think of them as very short-acting sulfonylureas. They also stimulate insulin release, but their effect wears off much faster.
How does that short action make them useful?
Their big advantage is dosing flexibility. Because they work so quickly and briefly, they must be taken with each meal. But the flip side is, if the patient skips a meal, they must skip the dose for that meal too. This makes them a good option for people with irregular eating patterns, as it helps avoid hypoglycemia if a meal is missed.
Interesting. Okay, next class, the thiazolidinedionins or TZDs or glitazones. Pioglitazone actose is the main one now. These are the insulin sensitizers, right?
Yeah, that's their primary role, yes. They work mainly by making the body's tissues more sensitive to the insulin that's already there. They improve receptor function, but they work slowly. It can take several weeks or even months to see their full effect.
And they come with a pretty significant warning label.
A major one. TZDs have a black box warning because they can cause or worsen heart failure. They're absolutely contraindicated in patients with established moderate to severe heart failure, NYHA class 3 or 4. They also commonly cause peripheral edema, fluid retention, and weight gain, which can really complicate heart failure management.
Yeah, that's a big one to watch for. How about a class that works entirely differently, right in the gut? The alpha-glucosidase inhibitors like acarbose, Precose.
Right, these work locally in the small intestine. They inhibit the enzyme alpha-glucosidase, which is needed to break down complex carbohydrates into simple sugars. By doing that, they delay glucose absorption after meals, helping to blunt that big post-meal blood sugar spike.
Timing must be key then.
Absolutely. They must be taken with the first bite of each main meal to be effective. And there's a crucial point about hypoglycemia. If a patient taking a carbose becomes hypoglycemic, maybe they're also on another diabetes med, you cannot treat it effectively with table sugar, sucrose, or fruit juice.
Why not?
Because I-carbose blocks the breakdown of those complex sugars. The treatment needs to be a simple sugar that doesn't require that enzyme for absorption, like oral glucose tablets or gel, or a severe IV glucose.
Good distinction. Okay, now let's get into the newer classes that have really changed the landscape. The incretin mimetics. There are two main types here.
Yes, there are the DPPIV inhibitors and the GLP-1 receptor agonists. The DPPIV inhibitors, like sitagliptin and Januvia, work by preventing the breakdown of the body's own natural incretin hormones. These hormones normally help increase insulin secretion and decrease glucagon after meals. By making them stick around longer, you enhance those effects. A key risk noted with this class is potential pancreatitis.
And the GLP-1 agonists, like liraglutide, Victoza, or dulaglutide, Trulicity, these are injectables.
Right, these are injectable. They directly mimic the action of the incretin hormone GLP-1. So they increase insulin secretion, only when glucose is high, which is good, slow down how fast the stomach empties, making people feel full longer, and suppress glucagon release.
And they often have that side effect people actually like.
Yes, significant weight loss is common with GLP-1 agonists, often around 5 to 10 pounds, sometimes more, which is a huge benefit for many type 2 patients. However, it's important to know they share a black box warning regarding a potential risk of thyroid C-cell tumors based on animal studies.
Okay. And the final major class, another game changer, the SGLT2 inhibitors. Drugs like canagliflozin, Invokana, empagliflozin, and Jardiance, these work in the kidneys.
Completely different mechanism, totally independent of insulin action. They block the SGLT2 protein in the proximal tubules of the kidneys. This protein normally reabsorbs glucose back into the bloodstream. By blocking it, these drugs cause excess glucose to be spilled out into the urine.
So you literally pee out sugar.
Essentially, yes. That's glycosuria. And because you're losing calories this way, they also tend to cause weight loss. Even more importantly, several drugs in this class, like empagliflozin, have shown significant cardioprotective benefits, reducing risks of heart failure hospitalization and cardiovascular death in certain patient populations.
Huge benefits. But forcing sugar into the urine must have downsides too.
It does. The most common side effects are genital yeast infections in both men and women, and urinary tract infections, because that sugary urine is a breeding ground for microbes. There are also rarer but serious FDA warnings about risks like DKA, sometimes even with normal blood sugar levels, and a severe genital infection called necrotizing fasciitis of the perineum, or Fournier's gangrene.
Wow. Lots of benefits, but definitely risks to monitor. Okay, we've covered a huge amount of pharmacology. Let's bring it all together. How does all this knowledge translate into safe nursing practice at the bedside? What's the absolute first step?
Assessment, assessment, assessment. You must always check the patient's blood glucose level immediately before administering any insulin or any other diabetes medication that carries a risk of hypoglycemia, period. You never want to cause iatrogenic hypoglycemia, meaning drug-induced low blood sugar, typically defined as less than 70 mg/dL.
And we talked about complex timing glipizide 30 minutes before breakfast or carbose with the first bite. How critical is adherence, and what happens if a patient is suddenly NPO, nothing by mouth?
Adherence is vital for effectiveness and safety. If the timing is off, the drug might not work well, or worse, could cause hypoglycemia as given without food. And the NPO situation is a classic safety scenario. If your patient is made NPO for surgery or a procedure, you absolutely must contact the prescriber to clarify the orders for their diabetes medications, especially insulin and sulfonylureas. Doses usually need to be held or significantly reduced to prevent a dangerous drop in blood sugar when no food is coming in.
Never assume. Always clarify.
Always. Never give a meal-related dose if the patient isn't eating.
Okay, so what if hypoglycemia does happen? How do we treat it? Is it different if the patient is awake versus unconscious?
Good question. For mild to moderate hypoglycemia, maybe they feel shaky, sweaty, confused, but are awake and able to swallow, we use the rule of 15s. Give 15 grams of a simple, fast-acting carbohydrate. That could be 4 ounces of fruit juice, regular soda, not diet, or 334 glucose tablets, or even hard candy. Then recheck blood sugar in 15 minutes, repeat if needed.
And if they're unconscious?
That's a medical emergency. They can't safely swallow. If you have IV access, the standard treatment is an intravenous push of D50W, 50% dextrose solution. If there's no IV access readily available, the alternative is an injection of glucagon. Glucagon stimulates the liver to release stored glucose.
Is there a safety consideration after giving glucagon?
Yes, a very important one. Glucagon often causes vomiting. So as soon as you give the injection to an unconscious patient, you need to turn them onto their side into the recovery position. This helps prevent aspiration if they do vomit.
Crucial detail. Finally, wrapping up with patient teaching. This is lifelong management. What are the absolute must-cover points beyond just taking the meds correctly?
It really is a partnership. Patients need to understand this is a marathon, not a sprint. Key lifestyle points are huge. Smoking cessation. Smoking dramatically increases cardiovascular risk. Achieving and maintaining a healthy weight, regular exercise. And meticulous foot care is non-negotiable, especially if they have neuropathy.
What does meticulous foot care involve?
Daily inspection of their feet, using a mirror if needed to see the bottoms. Washing feet daily and drying thoroughly, especially between the toes. Checking water temperature with their hand or elbow, not their feet, before bathing. Never going barefoot. Wearing well-fitting shoes. And checking frequently for any cuts, sores, blisters, or changes in color. Catching problems early is key to preventing infections and amputations.
And one more thing.
Yes. Emphasize wearing a medical alert bracelet or necklace at all times. It needs to clearly state they have diabetes and list their medications, especially insulin. This can be life-saving in an emergency if they can't speak for themselves. So just to quickly recap the big takeaways from our deep dive today. Remember, type 1 means insulin replacement is essential. Type 2 involves tackling resistance and sometimes deficiency. Insulin types vary hugely by speed and duration that timing is everything. Metformin is first line for type 2, but watch that kidney function and contrast-dye interaction closely. Glutazones have that serious heart failure warning. And the newer agents, the GLP-1s and SGLT2 inhibitors, are really exciting because they offer benefits like weight loss and proven organ protection beyond just lowering blood sugar.
That leads perfectly into a final thought. We know the major long-term dangers of diabetes are things like heart attacks, strokes, kidney failure. Given that these newer drug classes, the GLP-1 agonists and SGLT2 inhibitors, have actually proven they can protect the heart and kidneys, how might their use change the way we start treating type 2 diabetes? Could we see a shift where protecting those organs becomes the primary goal right from the beginning, maybe even more so than just hitting a specific A1C number initially? Something to think about.
It's definitely where a lot of the conversation is heading in clinical practice.
Yeah.
A very provocative question indeed. Thank you for sharing your sources and for joining us on this deep dive.
Absolutely. Thanks for walking us through it. We'll catch you next time.